So let's start the lecture. So this lecture is going to be on acid and alkali toxicity, which is again a very important, relevant topic in the field of medical toxicology. Not only causes accidental and deliberate poisonings, but also sometimes it brings in a medical legal significance as well, because it is sometimes used as an act of homicide also. Right, so during this lecture, you're going to learn about how to classify the corrosive agents, understand their mechanisms of injury, recognize the clinical features, and outline the management principles, and finally recognize some of the common complications and controversies around the management of corrosive agents as well as other toxicities. If you look at the definition of corrosives, so corrosive is taken as a substance that can cause, that has potential to cause chemical tissue destruction. So most of the time, these corrosives are either strong acids that has a pH of less than 2, or strong alkali that has a pH of more than. And it can cause local injury, it can cause burns, when it gets instilled on your eyes, it can cause damage to the eyes. As ingested, it can cause a wider systemic toxicity in the spinal tract. If you look at epidemiology, injury analysis conducted in the last year has reported over 6,000 cases of significant toxicity involving corrosive ingestion. And in that series, they have noticed nearly 65% as intentional ingestion. So, children can ingest, but corrosives mainly used as an agent to cause deliberate poisoning or sometimes homicides even. And out of the corrosives, acids and alkali, so alkalis emerged as one of the most frequent substances ingested, accounting for nearly 50%. And it carries high mortality. The pooled mortality of all these cases was 6.2%. And also it had also a very high reported incidence of stricture formation, nearly 1/4. So they concluded as tailored severity-based approach are required, and because of the deliberate ingestion, psychiatric screening is quite necessary, as well as early endoscopic interventions to prevent strictures, as well as the more serious cases have to be dealt with surgery. If you look at South Asian context, we see, more commonly compared to developed countries, corrosive ingestions are far more common. And household cleaners account for a majority of cases, especially in accidental ingestions. But strong alkalis, strong acids are used ingestions. And problem with our context is we don't have laws or the use of source aspects. So they circulate in unity and then that result in higher incidence of poisoning in areas of South Asia. And if common acids, we are quite familiar with these acids. Almost all of them have a pH of less than 2. Hydrochloric acid, sulfuric acids. So they are used commonly in industry, as well as sometimes used as battery acid, things like hydrochloric and nitric acid, and also phosphoric acid. And common alkalis, they are mainly contained in high power drain cleaners, sometimes toilet cleaners. So, and most of the substances contained as alkali include sodium hydroxide, potassium hydroxide, calcium hydroxide, ammonia, and sodium hypochlorite. So all of them have a pH of more than 12, have the potential to have a pH more than 12, can result in serious injury. What factors determine the severity? pH. So pH is very crucial. So some of the acids have a pH minus, so it's kind of very acidic. So lower the pH, higher the acidity, and higher the pH, higher the alkalinity. So the pH matters, as well as the concentration. So highly concentrated acids and alkali have the potential to cause more harm. And volume ingested, as well as the duration of contact, and the physical form matters too. For example, if you ingest a solid corrosive agent, they mainly get stuck in your upper respiratory or the upper GI tract, including oropharynx and hypopharynx, and they produce more extensive damage to the upper part of the GI tract, whereas liquid agents, they can transit rapidly, causing injury to the esophagus and the stomach. And the intense, the deliberate ingestions or homicidal damage can result in higher toxicity, as well as co-ingestion can complicate the presentation. The mechanism of injury, if you look at how acids cause their injury, so they mainly cause coagulative necrosis. And this coagulum limit the extension of the necrosis, resulting in a scar. So on one side, it is useful because this limitation will result in a kind of control of the necrosis. Therefore, with acids, you don't see transmural necrosis commonly, as it is seen with caustic ingestions. And with time, it can cause denaturation of the proteins, formation of an eschar, and also acids can cause more gastric damage as the complication. If you look at the alkali, they instead cause liquefactive necrosis, resulting in saponification of fat. And because there is no coagulum formation, it results in necrosis spreading across, but not limited to the entire length of the esophagus. So it can cause transmural necrosis both at the stomach and the esophagus, and sometimes it can erode into the surrounding structures, resulting in necrosis of the surrounding vital tissues as well. So it has the potential to cause deeper tissue penetration compared to acid-mediated injury. And alkalis are more commonly associated with severe esophageal injury, including transmural necrosis. It's useful to recognize the phases of injury. There are mainly 3 phases of injury. So during the early phase, during the first 3 days following an ingestion, you see that period is called acute necrosis. Mainly that result in the process of coagulative necrosis or liquefactive necrosis, damage to the cells, cellular proteins, and then ongoing inflammation. After 3 to 5 days, like during that period, that results in more ulceration and starts healing with formation of granulation tissues. That is kind of that forms the foundation for subsequent formation of scars. There'll be tissue sloughing, and also result in formation of an ulcer bed. And with time, with more and more healing, about 3 weeks after the ingestion, it can result in adhesion formation between the granulation tissues as well as scarring. So this scarring can result in stricture formation several weeks after the episode of ingestion. Oropharyngeal injuries, it can happen with the physical forms like solid forms as well as during the early phase. So the patient can present with severe oromucosal pain, drooling, you can see ulceration, and oromucosal injuries are mainly associated with airway compromise. So it can result in airway swelling. Patient can present with stridor, difficulty in breathing, and airway management can become extremely difficult at times if there is swelling of the airway. So intubation will be an extremely difficult task. Esophageal injury. So these patients, they present mainly with udinophagia, difficulty in swallowing, as well as dysphagia. The process is the same. It can cause ulceration, necrosis, and carries the higher risk of strictures when it comes to esophageal corrosive damage. So you can see in these images low-grade injury versus high-grade injury as shown in the endoscopic images, and Zaga classification grade 0, 1, 2A kind of belong to the lower grade, whereas if you when you climb from 2B to 3B, you see more extensive damage, indicative of a lesser favorable prognosis. And gastric injury can present with gastric pain, and they can present bleeding, and high risk of perforation because stomach stores these acids of alkali and can result in perforation. In the picture, you see a perforated in of alkali. Another theory from use it also results so this can act in cascade, resulting in metabolic acidosis, electrolyte imbalances, and it can cause renal acute kidney injury as well as shock. So the clinical presentation of these patients can be one or more of these symptoms. It can be severe pain, can be at the oromucosal or eye pain, skin pain, or wherever at the contact of exposure, or it can be the retrosternal or the gastric pain, and patient will complain of vomiting, nausea, or can drool because of the significant pain in swallowing. They can have hematemesis, as well as when the larynx is burnt, they can present with stridor and hoarseness. So you see one or more of these features during the early phase as clinical features, and there are certain red flags we need to identify early, and then escalate your management. These type of children will definitely patients will need certainly ICU care management from an MDT group of professionals such as surgeons, endoscopists, and ICU specialists, anesthetists, and specialty. So these group of patients, they present with stridor, so that indicates an impending airway damage, airway risk, and hypotension that indicates severe systemic upset. Severe abdominal pain might indicate an ongoing or imminent perforation, and altered level of consciousness. So that includes severe systemic toxicity. So your initial response depend on the risk assessment. So you need to assess the risk, assess the patient's condition, symptoms, take the set of observations, identify any comorbid factors, and assess the risk, including the pH of the solution, duration of contact, and co-ingestions, the intent of ingestion, and so on. And with that, if the patient is critically ill, then first we need to pay attention to airway, because airway management can be very difficult when the edema sets in. So early intubation, ventilation is recommended. Evaluate the breathing as well as stabilize circulation if there are any circulatory derangements. One thing that we should keep in mind and not do is that inserting a nasogastric tube, especially after a few hours, there will be extensive necrosis and it will spread. And if you put a NG tube and then start poking on the tube, trying to put it in, it can sometimes make a perforation happen and resulting in significant toxicity. So don't insert an NG tube until we have done the endoscopy and then ruled out any risk in those with symptoms, especially epigastric pain and retrosternal chest pain. So airway management, early intubation is important. It is recommended that rather than using a rigid instrument, using a fiber optic, which are more flexible and less risk of mucosal damage, can be used. And also remember not to attempt any traumatic intubations, because it can easily cause perforation and systemic toxicity. Breathing support if the patient is having stridor or difficulty in breathing, oxygen therapy, and these patients also can aspirate. We need to monitor for aspiration. We can do chest X-ray later on. And if the patient is respiratory-wise unstable, we have to arrange early intubation and ventilation. And circulation management, so put IV access to IV access and prepare to treat shock if a patient is presenting with shock, and fluid resuscitation. It's good to do a series of blood gases to look for lactate levels because it can cause severe metabolic acidosis. And about decontamination, there is a place for decontamination, but not for oral decontamination. But if there are contaminated clothing, so you can do the surface decontamination, remove them, and if the items are filled with corrosives, irrigate with copious amounts of water until the pH there is neutral. However, we should remember that we should never induce vomiting in the presence of corrosive ingestions. Also, do not administer oral fluids as neutralizing agents because they can cause exothermic injuries resulting in more thermal damage in addition to the chemical damage. And also, do not ever administer activated charcoal that can result in more damage, as well as do not attempt any pH neutralization actions. And oral dilution, the problem with oral dilution, if the patient is stable enough and not having serious pain, then you can start small sips of water, but not neutralize. If you give large volumes, if you give it as a neutralization, there is on one side, there is a risk of aspiration, and on the other side, there is a risk of exothermic reaction. So exothermic reactions are kind of these chemicals that interact with fluids and then generate more and more heat. So in addition to chemical damage, they can also affect by more thermally induced damage, resulting in more accelerated necrosis. And also they can result in gas formation, and they can make the injury worse because of the interaction of the chemicals. And support care is very important. So after you assess if the patient does need immediate attention, so patients are likely to be in severe pain. So we need to start analgesics early. And if the patient is having symptoms, severe pain, the patient can kneel back and then start on IV fluid. And this can be done until injuries endoscopy, which has to be done within the first 24 hours. And also, proton pump inhibitors, gastroprotective agents can be commenced. And other thing is commencement of broad spectrum antibiotics can be given to prevent possible sepsis that can happen following widespread tissue as and surgical has to be done, especially in cases, especially when you suspect full thickness necrosis or operation. And if the patient is intubated, then you need to consider other supportive care as well, which is recognized by this mnemonic, which is easy to remember. Fast hugs in bed. So what do they denote? Like these are the aspects that we need to think of, but not necessarily that we need to do everything, right? So think about giving fluids, feeding, so making sure the patient is well hydrated, analgesics, sedation. So it's quite useful in the presence of the severe pain. Thromboprophylaxis. Sometimes these patients are immobilized, kind of immobilized for a certain period of time, especially when they have cutaneous burns. So thromboprophylaxis, head-up position, to prevent aspiration, prophylaxis for gastric ulcerations with proton pump inhibitors and H2 receptor blockers, glycemic control, making sure that the patient is not having any metabolic derangements like hypocalcemia, hypokalemia, or hypoglycemia, spontaneous breathing trial, that is, if you're intubated, bowel care, and catheter change or removal of catheters, and then de-escalation of antibiotics once the patient is making a recovery. And lab investigations, all of these patients who are symptomatic, they have to have serum electrolytes, blood gases to determine the lactate, and serum calcium, kidney functions. And because sometimes, when you ingest certain acids, they interact. For example, if you ingest phosphoric acids and hydrochloric acids together, that can cause systemic effects such as severe hypocalcemia, hypokalemia, and metabolic acidosis. So it's good to have an eye on these metabolic abnormalities and monitor and then correct if it is necessary. And all patients with persistent vomiting, oral burns, drooling, abdominal pain, they require further investigation, mainly the endoscopy and plus or minus CT of the thorax and abdomen. And endoscopy is traditionally done within the first 24 hours because we should not delay it. Because if you do it later, like when the more and more local tissue damage is happening and necrosis is progressing, then your endoscope can iatrogenically perforate. So it has to be done early, ideally within the first 12 to 24 hours within the injury, so that you can have a careful examination of the mucosa of the esophagus and the stomach. And also, nowadays, we also tend to do CT scan, that is to identify the structure of the esophagus and the stomach. So there are helpful signs that you can see if there is evidence of severe necrosis or perforation that can be, predicted. That can be predicted with more accuracy by doing a CT scan. So imaging, not only CT, like, if the patient is severely ill, you can consider doing chest X-ray. One thing to assess for evidence of aspiration pneumonia. Other thing, you can look for any evidence of pneumothorax or pneumoperitoneum because of the perforated esophagus or perforated stomach. And CT can be used, like I told, for assessment of the depth. So they assess evidence of transmural necrosis, partial necrosis, and so on. And also, as seen in this X-ray, it's useful to look at the free air under the diaphragm, which indicates perforated stomach in this patient. And CT, so CT can be helpful to grade the local necrosis, so you can see the cross section of the wall of the esophagus or the stomach, depending on the presence or absence of wall thickening, edema, soft tissue infiltration, presence or absence of air bubbles, presence or absence of free mediastinal or peritoneal air or fluid collection. Then you can grade as grade 0, 1, 2, 3, and so on. And then grade 2 and grade 3 indicate increased risk of stricture, serious damage, as well as later long-term risk of causing esophageal cancer. So you see in this image the CT showing corrosive injuries leading to esophagus. So in the arrows, you see the esophagus, mucosal damage as well as transmural evidence of necrosis, tissue damage can be understood. And endoscopy, so it has to be done early for the same reason I told to prevent the iatrogenic injury, has to be done within the 12 to 24 hours, and especially avoid the 5 to 15-day window if you want to do endoscopy. Like later on, you might want to do endoscopy to assess the strictures, but this is not the time period because the tissues, the necrosis is still actively ongoing. So it's better to avoid doing an endoscopy during this period. So this helps to have a careful look at the mucosa and then to grade the injury severity. So the severity classification we used using the endoscopy is called the Zaga classification of corrosive injury. There are 4 grades with subgrades. Grade 1, then 2A, 2B, 3A, 3B, and 4. So this grading is quite useful to prognosticate as well as to predict the future risk of having stricture formation. So you see the images, grade 1, 2A, 2B, 3A, 3B, and 4. So if you see just the edema and erythema, but nothing else, no hemorrhage, no erosions, no blisters, no ulceration, so it can be classified as 1. But if you have them, then it will be 2A. And then, the deeper the burns, these burns or the damages are, you see more extensive necrosis. And in grade 4, you see perforation. So if you see a perforation, so outcome, the mortality risk is nearly 65%. And if you see 2B or 3A level lesions in the endoscope, then that carries nearly 100%, like 200% risk of causing strictures. So these patients will need careful monitoring, follow-up, supportive care to recognize strictures earlier to plan this subsequently. And steroids, with the play of steroids is quite controversial. There is no agreement that they use steroids for a patient with corrosive condition. Means there can be institutional practice, but it is difficult to give it, because also sometimes it can result in perforation sometimes. But if it was severe, can try a steroid, and that can be sometimes yes. Apart from that, some cases are quite serious. They can result in perforations, acidosis, hypertension, and death. So this can warrant early surgical review and surgical correction, laparotomy. So indications include perforation, mediastinitis following esophageal perforation, peritonitis following stomach perforation, and extensive necrosis. So they will need, now if you have a transmural necrosis, that warrants dissection of that resection of that necrosed part and then do corrective surgery, because this necrosed parts can act as focus of sepsis, severe septicemia, and subsequent systemic toxicity. And patients who remain asymptomatic, like for instance, depend in your initial risk assessment, sometimes it can be very trivial. For example, a child who has licked, there may be oromucosal plain, but apart from that, child may not have actually swallowed it. So this group of patients may be asymptomatic. So still, then you need to observe these group of patients for at least 4 hours, and if the patients still remain asymptomatic and well with normal observations, then you can commence oral fluids. However, symptomatic patients, especially when they present with epigastric pain, abdominal pain, until you rule out esophageal damage, gastric damage by doing an endoscope, within the first 24 hours, these patients will need to be kept nil by mouth and then admitted for observation. On the other hand, the serious end, if the patient is having drooling, stridor, so you need to understand the imminent risk of airway compromise, and you need to contact ICU, anesthetist, experienced staff who can handle the airway, and then ensure that the patient is intubated and ventilated without delay. And other group is hemodynamically unstable patients. It can happen especially following perforation, mediastinitis, severe metabolic acidosis. So such group of patients will need CT scans as well as early urgent surgical consultation to arrange surgical exploration. And stricture formation is not a immediate complication, but you will see about 3-4 weeks after the corrosive injury has happened. And this group of patients will present with, after initial recovery, they will present with progressive dysphagia or udinophagia. So because of this risk, these patients, all of these patients will need long-term follow-up. And then if the patient's having obstructive swallowing, difficulty in swallowing, obstructive symptoms, then they warrant early endoscopy. So you see in these 2 images, in one showing esophageal stricture, the endoscopic view, and the other you see in a contrast study showing the stricturing or stricture formation in the lower esophagus. And management of the strictures include mainly endoscopic dilatation. Sometimes you may have to insert a stent, or sometimes in extensive stricture formation, it may not just be dilated, but you need a surgical reconstruction. So it can be one of these treatments that is indicated for the stricture. And also, especially following acid burns, so it can result in gastric outlet obstruction, acquired pyloric strictures. So they can again present with abdominal distension, vomiting. It's a delayed complication. So persistent vomiting can be the most likely presentation, and again needs referral to the surgeon and then surgical management. So the message is like, any patient presenting with severe epigastric pain, severe retrosternal pain, you need to get the opinion from the surgical team and the endoscopy team to arrange an urgent endoscopy as well as to assess the need for any active surgical interventions before you start fluids or do anything else, after you start the pain relief properly. And other kind of long-term, like quite a long-term complications include strictures can lead to later development of esophageal cancers, and some group of patients may be left with chronic dysphagia. Even if their strictures were dilated, they can continue with chronic dysphagia, and that can lead to eating difficulty, chronic pain. So that can result in a lot of psychological trauma as well over the long run. Pediatric considerations. It is mostly accidental. Deliberate is quite rare unless if you see in teenagers. But the thing is, like, children are made smaller and more immature body organs. Even the small volume can result in significant damage. For example, like you see in this image, nearly oral cavities fractured following contact with a caustic agent. So that can not only compromise the appearance, but also feeding, and they are growing, so that can affect their nutrition, growth. So there can be a more additional burden than when it occurs in an adult. And intentional ingestion, which is common with caustics, they tend to ingest larger volumes. That carries a higher mortality, and psychiatric evaluation is mandatory in all cases of deliberate poisoning. Not only evaluation, but also these patients will need to be followed up properly to identify the ongoing risk and the risk of recurrence. Dermal exposures, so that can cause chemical burns. So in these cases, installation into eyes or skin burns, irrigation is essential. So you need to use copious amount of water and rinse it, and then make sure the pH is normalized with your diluting agent. The damage should depend on the pH of the agent, the depth of the burn, duration of contacts, and so on. So immediately, otherwise it will lead to corneal scarring as well. So it on pH of this fluids is neutral. So it has a long iteration. As far as the pH will high range, you need to rinse it with water. And urgent preventive strategies, very important. Yeah, sorry. So they can mistake these bottles to drink bottles and then accidentally ingest, and that can result in serious oromucosal burns. And as a country or as a region, regulation of these agents is quite poor, and they are in free circulation everywhere, not regulated. People are not made aware about the toxic effects. And when you have more toxins in your surroundings like this, and if you have kind of depression thoughts, then you easily access this without knowing the lifelong risk or the suffering that it can bring on. So it's very important to regulate. So regulatory control will be the key as methods of prevention. So the key take-home messages that I would like to deliver to you: alkalis, remember, they cause deeper injury, more damage, transmural necrosis, higher risk of perforation compared to acids, but both can be quite detrimental, both can result in mortality. And early RV assessment is critical. So recognize this group of children. They might present with drooling, they might present with stridor. So don't wait until you become helpless. So you get the team on board, maybe the anesthetist, ICU team, RV team. So you need to get their help without delay to manage RV emergencies. And consider doing endoscopy within 24 hours. So the group of patients presenting with severe epigastric pain, abdominal pain, may just be enough for you to consider referring to the surgeon and then have a look and then decide on endoscopy. Because sometimes, you don't have to present with excruciating pain. for you to decide. But presence of these in the early phase, and then with damage, more and more damage, the patient can present with serious damage to the mucosa and the wall of the esophagus and the stomach. And avoid neutralization in ingestions because it can cause exothermic injuries, as well as it can form gas formation and it can worsen the injury. But surface decontamination is very important in the presence of instillation to eye or skin burns. And management is mainly multidisciplinary. So think about getting others involved, especially the surgeons here, and as well as the services from the toxicology if needed. So that concludes my presentation. But